So I'm going to move on from what Sinead was saying about here's one we made earlier about population-based registers and the advantages of those. I also want to point out that even though the scenario that Sinead painted sounds a bit depressing in the sense that we're the lowest number of neurologists in Europe, when I was appointed in Ireland as a neurologist back in the last millennium, last century, I was the 11th neurologist in the whole country. So we have 66 neurologists, so it is an improvement, but of course, two things are happening. One is the population in Ireland is growing, and the other is that the pace of research, particularly in the neurological space, has grown exponentially. So it's not all doom and gloom, and we can show that we can increment rapidly as we have done over the last 20 or 30 years. So the future is bright, I think. I'm going to talk a little bit about the work that we've been doing in really capitalising on what Jennifer was saying earlier, about what the Minister was saying earlier, about the benefits of living in a country like Ireland. And there are genuine benefits, despite all the negative talk that people have about the country and what a mess we are. We are an island, and that has its advantages. We have a relatively stable population structure. We're welcoming new people into Ireland. That doesn't mean the population structure is not stable. It makes it more diverse and healthier, actually, in my opinion, genetically definitely healthier. But we still have a high level of interconnectivity. And this is really important. Connectedness and social cohesion is really important. I was getting a lift in today and I was reading, so I didn't have to talk to my husband, I was reading my phone. And no, that's not true. I was talking to him as well. But we're the second most peaceful country in the world on the Peace Index. Iceland is more peaceful than us. So we have and that's partly to do still with our social cohesion. We're in the centre of the GAA, and the GAA is a very good example of social cohesion. It knits communities together. So we still have a very high level of interconnectivity. And anybody who's Irish by birthright will know this, because it's impossible to meet somebody from Ireland if you're somewhere else and actually not find some commonality, somebody that you knew. And I lived in Boston for 5 years, and we met Irish people. Within the first 10 minutes, we'd find we were either related to each other or we knew people who were related to each other. So that connectivity is really important. Another advantage of the fact that we were a bit slow off the blocks in developing our centres, in developing our neurological expertise, is that organically we built these very large centres of excellence. Because we had so few neurologists, these neurologists, like Sinead and myself, were able to build centres where we could really build expertise within those centres. And it's not an accident that Sinead is recognised internationally, for example, in her work on ataxia and the peripheral neuropathies. And our centre is recognised internationally for motor neuron disease and some of the other neuromuscular diseases. And it's an organic process. It was a natural result of having so few neurologists in the country, and that's good. That was good in one way. As the Minister said, we also have very motivated clinicians, most of us trained abroad for some of our lives, and so we're both motivated in clinical research and clinical activity, and we're also well connected internationally, and that's really important as well. And really, really important is this sort of group, the voluntary organisations, and we're unusual compared to other countries, and I do a lot of work around Europe, and I lived in the US. The strength and the cohesion of the voluntary sector in Ireland, of Muscular Dystrophy Ireland, and the other voluntary organisations who came together actually back in 1999 as the Neurological Alliance. And that's really unique. There are very few organisations like Muscular Dystrophy Ireland and like the Neurological Alliance in other parts of the world, and that's really important. And that's a very strong strength. That's a very important strength in Ireland. And that all of those together have the potential to make an enormous difference. And they're suited to population-based registers. That all of those attributes of Ireland make Ireland a very good place to do population-based registers. And this is happening already with the Muscular Dystrophy Ireland register, which is about to start. And there are other registers as well. I know you've got some registers going as well, Sinead, and we have the motor neuron disease one as well. So why would we want to do population-based registers? Well, registers collect information of everybody in the country with a specific condition. And they're important because it means that we can most accurately reflect the range of and the type of the condition within the country, within the population. That's really important. It's important a register has nobody lost to follow up. If you have a clinic-based population and the person stops coming to clinic, You don't know what happens to them. And that's particularly the case in a large, well-resourced country like the US. They can't do population-based research because of the structure of their health system. But in Europe, but particularly in Ireland, it's quite difficult to get lost to follow up in Ireland because you'll always know somebody who knows somebody who knew somebody who knows the person. And if we've good volunteer organisations such as MDI, it's actually quite difficult to get lost to follow up. Doesn't mean people can elect not to join, and that's fine from a GDPR point of view and a privacy point of view. But if somebody gets lost to follow up by accident, we don't want that to happen. We can capture people who don't attend a specialist clinic, and Sinead was mentioning about the long travel times that people have. But if somebody's registered within a register and we have a mechanism to keep in touch with them, they don't necessarily always have to travel. We have other ways of collecting information. So we capture people who wouldn't be able to travel because they're too old or too sick or too poor. That's a big issue. Travel is expensive in Ireland. Very few countries can do what we can do. There are very few countries that can capture every person with the condition. And Ireland is one of those countries that can do that. And so that provides a unique potential for population-based registers in Ireland. So I want to talk to you a little bit about our register, because I set this up back in 1994 when I was 12. That's a lie. It's the longest running register in the world now. So we get some kudos for being able to run this register now for 31 years. The longest one. So we have over 3,000 cases now, 3,000 people who've had motor neuron disease that we've captured on our register. It's a really, really powerful instrument that we have. We see about 140 new cases every year from all over Ireland. And about 450 people are living with the disease, with the condition in Ireland. And we know who they are, and they know who we are. And that's really important. We also have a DNA bank, so we can engage in genetic studies. Motor neuron disease has more than one genetic cause. So trying to understand the genetics of motor neuron disease is very important. Now, setting up registers is not trivial, and it's much less trivial than it was when I set it up in 1994, when the ethics submission required one page and it trusted you. Now we're subject to quite a lot of appropriate legal and governance regulation. So, for example, the health data it's considered to be sensitive under GDPR in 2018, puts in additional restrictions. The Minister was talking about this, about how we need to smooth or streamline some of that. So data collection and storage and consent requires approval appropriately. But there's all sorts of other things that we have to do now. There's something called the DPIA, Data Protection Impact Assessment. We have to have additional data sharing agreements if we're sharing data. The data has to be codified. This is all to protect people, and it's appropriate, but it can create a lot of additional burden for people who are engaging in research. So we wrote a paper on this, which we published this year, just talking about setting up an international data, population-based data set called Precision ALS. So just walking through what the structures and governance structures and legal requirements are to do that. So in our clinic, it's a national specialty service, and we're recognised now by the HSE as being the national service for motor neuron disease. So we are, and I don't make any, I'm not apologising for this, we are a highly centralised service. So I want to see everybody that has motor neuron disease. I want to personally see them, or one of my team. And then we can see the person, we can generate a care plan, and then we can continue to impact on their care by either them coming to us or us going to them. So we have a system where we have outreach operating. We work really closely with the Irish Motor Neuron Disease Association. There are benefits in the same way as there are benefits to joining MDI. IMNDA provides advice, support, equipment. They have nurses. So there's an advantage to people who have motor neuron disease to be members of IMNDA, and there are advantages for us to be linking with IMNDA, and everybody gains in that. So everybody is consented to allow inclusion of their information at the time of the first encounter with our service. That might be with us, but it might be part of our research, our outreach programme. We can send nurses out or doctors out into the community to see somebody who's not able to come to the clinic. And then we can follow up with the phone interview. And so we ask anybody who comes to our clinic to give us a blood sample for our bank as well. So we've done a lot of work thinking about registers, and that's a paper we published a few years ago about population-based registers and about the sorts of biases that you might be able to see that might occur in a register. And there are things that we can miss in a register, but understanding where those biases are is very important. What can registers do for us? Well, I've made sort of 4 points here. One is epidemiology, or tracking the number of patients, and Sinead mentioned that in these rare disease conditions where if we know that they exist, we can track them. And we did this with the population-based study that we did, the cross-sectional study with Stella Lefter a few years ago. It's important for service development as well. Deep phenotyping means to characterize what's going on with the person, because not everybody's the same with these conditions, so it allows us to recognize the condition to a greater extent. Then genetic epidemiology, understanding the gene variants within the community is very important, because a lot of the therapies that are coming down the track have a genetic basis to them, so we need to know if people would be suitable. And then the final most important one is clinical trials. I'm going to spend a little bit of time at the end talking about that. So we've been studying the epidemiology of motor neuron disease over the years, and we've done loads of mathematical, statistical. I can say I actually made somebody else do that, because I don't really like doing statistics, but I've had very bright people over the years doing it. So that our age of onset of motor neuron disease has gone over, has increased a bit, suggesting population is healthier and aging more healthily, and age is one of the factors. And then we've looked at things, something called age period cohort effects, and we found that there's people who were born between 1932 and 1942 had a slightly higher risk of developing motor neuron disease, and we think that has to do with the time of extreme deprivation in Ireland. It was just after the foundation of the state and during the emergency, when there's a trade war going on with the UK, and then also the Second World War. So people born during that time, it seems, had a slightly higher risk of developing disease. And that's important, that's research, and that allows us to build some hypotheses around disease risk, which we're developing now. But really, from the point of view of epidemiology, this has a huge advantage for health services research. And that's, the Minister is very driven by this idea of data. Data to drive services. And if you have a register, you can generate the sorts of requirements of data that the policymakers need to develop really good services. So we were able to, using this evidence-based, the incidence and prevalence of disease, why do we need specialist clinics, and what the outcomes might be, and what are the benefits from a health, economic and quality of life to interventions that we're doing. And we can also work with the HSE about clustering, so we know where everybody is in the country. So we've had requests by the HSE to say, we've had people from a part of the country say there's 6 people or 8 people with motor neuron disease. Is there something in the community? And we can say, no, we've done the clustering study on this, and that's statistically not significant. So we do a lot of work from that point of view in terms of ameliorating concerns that people might have. We've also been able to show that if you attend a specialist clinic, a highly centralised specialist clinic, and you're linked with us, you do better. And we were able to do some analysis looking at a comparison between a specialist clinic, but with devolution of services in the north of Ireland compared to a really specialist clinic like we have. And people do much better. They live longer and they have a better quality of life when they attend a highly specialised service. So that was a rationale for the HSE funding our service in its entirety, including our entire multidisciplinary team and our outreach nurses. And also to reflect something that Sinead said, a clinical trial service as well. So the HSE is actually supporting them. Not sure they really realise they are, but they're supporting a clinical trial service as well. We're also able to recognise the different subtypes of disease. And motor neuron disease, only about 15 years ago, people didn't realise that there was a bit of thinking problem in motor neuron disease. We were able to really fully characterise that in Ireland. And using those sorts of data that we can generate, then we can start looking at people and say, okay, so we think you're in a good or a bad prognostic group in terms of the progression of your illness. And then we could use our data along with data sets from other countries to develop this very large prediction model for what might happen to somebody, and that's very useful in the development of clinical trials. We can give a probability of progression of disease, and that can allow us to stratify or allow people to go into clinical trials in these progressive illnesses. So these are really important, and we contributed substantially to that algorithm that was built by my colleagues in the Netherlands. In terms of genetic epidemiology and genomics, that's really important. I want to show you some work that we've done by one of our PhD students, who's also a medical, Ciara O'Donoghue, who's looking at the population that we have and the genetic epidemiology, the genetics, the relatedness that we have of people with motor neuron disease, because we've run a register for 30 years. We have 3,000 people, and we know that some forms of motor neuron disease are genetic, but to what extent and what the level of the genetic risk might be isn't very well understood. So we can use something called identity by analysis, which is looking at pedigrees or families where we know there's motor neuron disease, and then using their DNA to determine how related people might be to one another who didn't know they were related to each other. So here's an example of a patient that we saw in a clinic who didn't have anybody in their family with motor neuron disease. And so Kira was able to show that that person genetically was related to another person in pedigree 6, but they were also related to a person in pedigree 5 who actually came from a very large pedigree that was also related to pedigree number 11. And then they were related also to pedigree number 10. And then they were also related to another pedigree. And they were able to look at people where there was an unusual presentation where one person with motor neuron disease, but we see some families where there are other neuropsychiatric conditions within the family to a higher extent than there should be. And so she was able to look at this pedigree number 40, and that was related to pedigree number 43, pedigree number 42, and pedigree number 41. And that's very important. That allows us to contribute internationally to our understanding of genetic risk. And understanding genetic risk allow us to understand the biology of what's happening, and in that way try to identify neurotreatments that are precision-based, the right targeted treatment to the right patient. And that gets into the idea of clinical trials. So clinical trials, and there are some members from the industry here, and they will agree with me that industry-sponsored trials are competitive. The pharma industry, much as we love them, they're not a benevolent organisation. They're an organisation that are supported by shareholders. Smaller organisations are funded by external funding I can't remember the term, but anyway. So these are the industry-sponsored trials want centres that can deliver in their clinical trials, and they set us up in competition with one another. So we have to tender for clinical trials. It's not like a company says, "Oh, I'd like to do a trial in Ireland." We have to say, "Come to us because we are the best. Come to us because we can do it. Come to us because we have the infrastructure, the expertise, the interested patient groups, and the ability." So we have to be able to sell our wares, and that's what the minister was talking about. If we look at our population in Ireland compared to Denmark, we do about 10 times less trials than they do in Denmark because they're much better organised at selling themselves in the Scandinavian countries. So successful tender requires a recognised centre of excellence who want to do a clinical trial. So a company will look at Ireland and say, well, we don't see where the patient is going to come from. Who's the PI? Who's the principal investigator? Who's going to support this trial? Who's going to make sure that you have enough patients? Who's going to make sure that the patients are the right patients for this study? Who's going to be able to recruit to clinical trials? And who's going to be able to keep patients in the trials and make sure that the patients are appropriately treated in the trial? So in order for us to do that, we have to have centres of excellence. And if we have centres of excellence that are well characterised and we're able to sell that by both publications, such as we've done with motor neuron disease, or by engaging with industry and showing them how good we are at doing this, that's how we get clinical trials into trial. They don't just happen by accident. They don't just happen because somebody wants a trial. We have to work really hard as clinicians to do that in partnership with people with the disability. And if we are able to do these clinical trials and we can combine with other like-minded centres across Europe, and Sinead mentioned that as well, to the European Reference Network, or we're part of a network called TRICALS, of which I'm the co-chair, and these are European centres with a long history of successful population-based registers, but also clinical trial delivery. So if a company comes to Europe, they go to TRICALS, and TRICALS will say, yeah, okay, Ireland, really good, very good. And the companies will also do their own due diligence on, okay, so of the previous trials that happened in Ireland, how many patients were recruited, how many patients were retained, what was the outcome, what's the centre like, are they able to do what they say on the tin? Really important. We have to be very sure that we can do this. And we shouldn't allow centres that aren't able to deliver that to engage in trials until we know that they're up to scratch, because it damages the whole Irish reputation. So registers, therefore, can be used to facilitate both clinical trials but new drug development as well. And the whole thing now, and Sinead mentioned this as well, is this concept of precision medicine. Not all drugs are going to work. Even if you have a condition that has a name, it may be that the drug may not fully work on the type of conditions you have. This is true in cystic fibrosis, for example, where there are gene therapies, but the different mutations have slightly different ways by which they cause CF, and not all drugs work for people with CF, and it's one of the rare diseases. So precision medicine is very important. So we're part of we're running a big international initiative called Precision ALS. It's an academic industry partnership with funded by Research Ireland, but with many funding companies, including funding pharma companies, including Biogen, that are supporting this meeting, to try and build a clinical trial ready cohort across Europe, but also to try and understand the disease in all of its iterations so we can really provide the right drug for the right patient at the right time, the right dose. To summarise, population-based register is useful for service development and research. I commend MDI for the population-based registers that they're about to start. We are a unique place to generate excellent registers. These types of mature registers that I've been running for the last 30 years can combine data, are very valuable for the reasons I mentioned, but combination of these mature registers across larger areas, such as across Europe, can provide really important insights and help to drive new research. Now, funding registers is really difficult because registers are seen as infrastructure. Nobody wants to pay for them. Even the ERN isn't actually giving us any money to build the register. We have to build the register for the ERN out of existing resources. So one of the things, and it's a pity the minister isn't here, that we need to really advocate for is to support the infrastructure for our rare diseases in Ireland to make sure that we are adequately funded to drive our registers forward, to make sure that we have really good population-based registers, because that pulls everything else in, including clinical trials. Now, the health regulation requirements in Ireland are generating additional burden, but there is a recognition of this, and the Minister was talking about this as well, about how we might try and improve and smoother, make smoother the appropriate privacy requirements, but at the same time not have this overburdensome for those who are engaged in these types of studies. So thank you very much for listening to me. Venture capital, that's what I was looking for. Venture capitalists fund small companies. Thank you.